Welcome to this OncLive News Network presentation, broadcasting live from MJH Studios. Today's discussion will be focused on practice changes for metastatic non-small cell lung cancer, specifically the implications of recent data and FDA approvals as far as their application to the clinical management of patients. I'm your host, Dr. Jack West, medical oncologist and medical director of the Thoracic Oncology Program at the Swedish Cancer Institute in Seattle, Washington. Today, I'm joined by three of my colleagues who are also experts in lung cancer and clinical research. Dr. Charu Aggarwal, Assistant Professor of Medicine at the Hospital of the University of Pennsylvania in Philadelphia, Pennsylvania. Dr. Greg Riely, Medical Oncologist from Memorial Sloan Kettering Cancer Center and Vice Chair of Clinical Research for the Department of Medicine in New York, New York. And Dr. Weiss, Section Chief of Thoracic and Head and Neck Oncology and Associate Professor at the UNC School of Medicine in Chapel Hill, North Carolina. During the next 60 minutes, we are going to navigate through some of the questions surrounding how we treat patients with metastatic non-small cell lung cancer today. We'll consider how the most recent clinical trial data will shape the path forward for the busy medical oncologist in community practice. In the last few minutes of the broadcast, we'll answer some of the questions that were previously submitted by our viewing audience. During the broadcast, we invite you to submit questions to our panel by using the entry field located below this video. So we'll start with the broad area of the many new trials and flood of new data that came in about treating patients without a driver mutation who have advanced non-small cell lung cancer, either squamous or non-squamous. And I think at the top of that list, at least as we would have expected going into the season of big meetings, was the Keynote 042 trial. And just to recap that, that was a plenary session presentation by Dr. Gilberto Lopez that we knew beforehand was positive for a survival benefit. And this was a trial for advanced non-small cell, squamous or non-squamous, who had PD-L1 tumor expression of 1% or greater. So that's about 2/3 of our patients. And it was a direct comparison of pembrolizumab monotherapy to doublet chemotherapy that was histology appropriate. And of course, we have already had a similar trial, Keynote 024, that came out in late 2016 as highly positive in the subset of patients that was narrower, with a PD-L1 level of 50% or greater. And this was broader to now include the 1 to 49% population. And we did see that, yes, it was positive for an improvement in overall survival in this broader population, but actually that the results, I would say, were very interesting in that we actually saw that the big benefits were in the patients who we already knew benefit from pembrolizumab monotherapy. The big dramatic benefit with pembrolizumab monotherapy was in the 50% or higher subset, and it diluted progressively as you added the patients with a 20% cutoff or a 1% cutoff. And when you look just at the group of patients with 1 to 49%, there was really no difference. In fact, the hazard ratio is 0.92. And so you could perhaps argue that, well, you did as well in efficacy and had a better tolerability with pembrolizumab. No surprises. We know what to expect for the chemo doublet. We know what pembro monotherapy does. But I think it was still significant that in the trial design for this, patients who were assigned to the first-line chemotherapy were not permitted to cross over as part of the trial to get pembro monotherapy second. And in fact, in this global trial, only about 20% of the patients ended up getting immunotherapy subsequently if they started with chemo. And so I think that is a real detriment and speaks to the difference between how it was performed and how it would be done in my practice, and I think most in the United States, where we have much better access and an expectation that if you didn't get it first line and you were ever a candidate for immunotherapy, you'd get it second line. My interpretation is that while it may be permitted to do this in the 1 to 49% population, it's not the most attractive option for that group. But I think that the big issues are that there are some more compelling options, namely chemo and immunotherapy. We'll talk about the non-squam population and Keynote 189, and we also got some more information in the squamous population as well. So let's start with 189. Greg, you can please just summarize the key points of this. This was not actually from ASCO, but still very timely, only coming out a couple of months ago.
Right, so Keynote 189 was presented first at the AACR meeting, but it's already published in the New England Journal of Medicine. And this was really a key trial looking at the question of, can we combine chemotherapy and immunotherapy? So the control arm here was platinum pemetrexed, so patients were allowed to receive either carboplatin or cisplatin. And then the experimental arm was combining platinum, pemetrexed, and immunotherapy, specifically pembrolizumab. And when we look at the outcomes of Keynote 189, regardless of PD-L1 status, regardless of performance status, patients did better if they got pembrolizumab plus chemotherapy rather than chemotherapy alone. I think regardless of how you approach initial therapy with regard to PD-L1 status, if you look at PD-L1 status or don't, this applies to all, for PD-L1 0, 1, or 50%. And so I think this was probably the most practice-changing trial we've seen in lung cancer over the last year or two.
So it's interesting that this, I agree with you, is practice-changing, but it's actually a regimen that was already FDA approved based on the Keynote 21G phase 2 trial, 123 patients, good results, but not universally adopted because of the size of it and the lack of a clear overall survival benefit. And so you would say that even though we had this available for us as a carbo, pemetrexed, pembrolizumab combination, this phase 3 presentation really changed the landscape.
Yeah, I think the original data that the FDA approval was based on was really provocative, showed a progression-free survival benefit. And I'm still adamant that a progression-free survival endpoint is a good one in the first-line setting. But when the question is whether sequential therapy would do as well, it's really important to look at that overall survival endpoint. And the fact that Keynote 189 showed a survival endpoint was really a big plus. And I think the other power in this study was that it was so much bigger, and so we're able to look at PD-L1 status and see more clear signals. In the original study, some of those PD-L1 numbers looked a little funny in that it seemed like some people with sort of mid-level PD-L1 staining didn't do as well as people who had no PD-L1. It was all very confusing. But when we see the 189 data, we see very clear progression-free survival, overall survival signals that really are across PD-L1 status, and it's very robust, and I think it's impressive stuff.
What do you guys think about your use of a platinum pemetrexed pembro combination both before based on the phase 2 data and approval, and then the subsequent FDA data, the subsequent phase 3 data from Keynote 189, and also its applicability across the PD-L1 spectrum?
So this was a very well-conducted trial, Keynote 189 was, and we really, as Greg pointed out, we are able to now really discern, because of the largeness of these three groups of PD-L1 expression being the negative 1 to 49 and greater than 50%, that no matter which group you were to use this in, the benefits still applied for the triplet. And personally, in using the triplet, I find that it's actually very well tolerated without adding much cumulative toxicity above and beyond what I would have obtained or had as a side effect with just chemotherapy alone. So I find that it's really practice changing and reinforces the data from the phase 2 trial.
Jared, your thoughts?
So 21G didn't change practice for me at all. In the greater than 50% population, or the 50% and greater population, I was already thought that single agent immunotherapy fit the human goals of my care a little bit better. And the question of interest to me would have been immunotherapy versus immunotherapy plus chemo, not chemo plus or minus immunotherapy. In this trial, there was greater crossover than in the 042 study. I think it was about 40% from the chemo alone arm, maybe 41.
A little higher.
but still imperfect. Some of that will be because the patients haven't progressed yet, but there was imperfect crossover here. And so I think this is practice changing. It makes that triplet, a reasonable option, perhaps a preferred option for the 0 to 49% patients. The question that remains for me is that in the real world, I think that crossover is much better than that. And my question is it mandatory to give it in front line? The PFS curves, to me, speak to an additive benefit, not a synergistic benefit. Then you get a better overall survival difference, particularly in the high expressors than you have on the PFS curves. And so I hearken back to some of our old data and ask, well, is this guaranteed exposure to the agent? But then I look at my practice and say, well, I think I cross over quite a bit more than 40-something% of people. And so I definitely think that this trial is practice changing in the sense of making that triplet eminently reasonable. My question that I have not fully resolved is for the 0 to 49s, is it mandatory or a sequential therapy guaranteeing exposure to immunotherapy in second line still reasonable? And my personal answer to not totally cop out is I think it's still at least reasonable.
I agree. I think that there were still differences where the best results with the combination was in the high PD-L1 group, in whom monotherapy remains a very strong choice, and you can avoid the issues and the side effects of chemotherapy, at least initially, and have that available for later. 1 to 49% were still, I would say, compelling benefits. And I would even say that the 0 group, or the less than 1%, had a benefit from the combination. But I agree with you, Jared, that the fact is that if you have 50% or fewer of the patients crossing over, it does lead to the question of, could you still do comparably well? The progression-free survival hazard ratio in the less than 1% was 0.75. The curves are kind of crossing over and touching in a few points. So I wouldn't say we want to be too heavy-handed that it is an absolute mandate to do this, particularly if you're really confident that the patient in front of you with more indolent disease or very good performance status, you'll be able to deliver it sequentially, if not concurrently. And I agree that that in practice, I think it's important to distinguish. People say, well, we only deliver a 50% rate of second-line therapy with docetaxel, looking back at our clinic records, but that's docetaxel, and I would say that there's not that much enthusiasm for it. The toxicity burdens are real. Very few of our patients are prohibited from getting immunotherapy for these reasons. I mean, if they were not candidates for immunotherapy second line, they were probably not candidates first line either. So.
But I will just add,
you first.
I would just add that our ability to predict as oncologists which patient will go on to second-line therapy is still limited. I think we still need more than just an intuition or gut to say this patient, okay, I can save immunotherapy for this patient for second line. I think there is value to giving the best, and whatever that best may be as defined by data, upfront, because we can't predict clinically who is or not going to make it to second line.
No, I think that's fair, but at the same time, there are costs to doing it all up front and burning that option, particularly if there are some data out there, imperfect though they are, that giving subsequent therapy can actually, you can get better results with chemo after immunotherapy, et cetera. I think that we still have a lot to learn about sequential, and I think it's fair to say there is a difference between a 20 or a 40% crossover, and in my clinic, it exceeds 80 or 90%. I would say that I think it's fair to argue the point of give your best up front, but still more to learn about this, particularly if we could deliver everything sequentially versus concurrent.
Yeah, and just briefly, I think that there's it's delightful how quick our data is moving, all these advances for patients. But one thing that's lost is the opportunity to ever learn important questions. And I think that there's a sequence question here that our data has moved so fast that I fear we may never answer. Whether is it best to use these agents all up front? Is it best to do a consolidation or maintenance serial approach? I fear we may never really learn that.
So one small point to make is that unlike the 21G trial, 189 included cisplatin or carboplatin at the discretion of the investigator. The benefits were comparable either way, There was a higher incidence of nephritis in Keynote 189 that would lead to some, at least vigilance, if not caution about that. And my own preference would be to favor carboplatin. I would say in the US that's the clear prevailing approach, but either would be a reasonable one. But let's move on. Another trial that was presented in one form at AACR back in mid-April, and then further facets of this very complex trial, Checkmate 227, presented by Dr. Haas-Borgay at ASCO very recently. And it's really a challenging trial with a lot of questions being asked. Jared, can you just outline some of the key points, both of what at least we've seen so far and what it might mean?
Sure. So this was a very simple trial that gave us an absolute answer. So this was a complex design. So patients were divided by their PD-L1 status in terms of how they were randomized. So those with a negative PD-L1 were randomized to ipi-nivo, nivo chemo, or chemo alone, where those with a positive PD-L1 marker, any level of positivity, were randomized to ipi-nivo, nivo alone, or chemo plus nivo. And actually, I think that from a human perspective, that was a reasonable way to design this. The other novel thing about this trial was the use of biomarkers. In addition to PD-L1, this trial looked at and pre-specified in its statistical plan analysis by tumor mutational burden. So we've heard some about tumor mutational burden. It is just what it sounds like. You do next-generation sequencing, and it's a number of mutations per megabase. And we've seen in prior data sets in melanoma, in lung, in head and neck, I think basically every time we've looked, that this is a predictive biomarker. And I think it makes common sense. The more mutations you have, the more potential immunogenic neoantigens you're going to have, potentially the greater efficacy of these agents. And we've seen that before. So what we saw at AACR and in the New England Journal publication that followed.
This was by Matt Hellman.
Was that for patients with a high tumor mutation burden, we have to be careful how we define that because it changes every 20 minutes. Yeah. But in this study, for a tumor mutation burden of at least 10, we saw the efficacy of ipi-nivo compared to the other arms, both in PD-L1 low patients and PD-L1 high patients, and both in squamous and in non-squamous histology.
So that was the specific breakdown of what they focused on was nivo-ipi versus chemo doublet, although they did include a bit on nivo as well, which kind of fell between the other two arms. But, and this was in terms of progression-free survival. There was a trend toward better overall survival, I believe, but not
early data, I think, on overall survival.
Right, fair enough. And then Dr. Borgay presented some additional data at ASCO, really just focusing on the low PD-L or the PD-L1 negatives, which showed that the nivo chemo arm did better than chemo alone, but that this was also in progression-free survival, and that was limited only to the patients with high tumor mutation burden. You lost that difference in
right, so this may be worth summarizing by the statuses to be a little. So he showed us two key curves in that. He showed us a lot of curves, but the two key ones were in the tumor. All of the patients had PD-L1 negativity in what he showed us. For those with high tumor mutation burden, the top curve was ipi-nivo, followed by nivo chemo, followed by chemo. With not huge numbers of patients at risk, actually, small patient numbers. But even smaller yet were the curves that he showed us for the double negative markers. So the patients negative for PD-L1 and for tumor mutation burden. I think it was 40 or 50-ish patients at the beginning of the curve. So essentially 3 phase 2 studies in terms of size. But what was interesting is those were absolutely overlapping curves. For the patients who were double biomarker negative, there seemed to be no benefit of integrating immunotherapy in any context. And given that while these agents may have lesser toxicity than cytotoxics, and I would say in my practice, I'm far less afraid of hurting people, at least with single agent immunotherapy, compared to cytotoxics, they're not a free ride. If you're that person with one of the rare severe side effects, it can be awful. And so if that hypothesis generated by these small numbers ends up being true, those are people that we could spare these risks.
So one of the other provocative findings, though still limited numbers of patients kind of early, is the long duration of the responses seen, especially with the nivo-ipi combination, where it ends up with pretty small numbers. I think one of the challenges is in interpreting the Checkmate 227 is you started out with over 1,700 patients, and you're ending up with all these subsets that end up being a few dozen patients overall. But it looks like in patients who were responding well to nivo-ipi, they were very long duration, which is, of course, a goal that
extremely important.
This
is what our patients come in asking for. And so I don't think it's inappropriate, all of the attention that's been paid to the tail of the curve. Right. Our patients don't use those words, tail of the curve, but in more human language, that's what every patient comes in asking for. They're not asking us for an average expectation of an extra month. They'll take it, of course. But what they come in asking for is some chance at being alive 2 years down the road, 3 years down the road. And that's so from a human perspective, that's extremely provocative. I strongly agree with your commentary, though, on paying attention to the number of patients. When you get to that tail, it's extremely small numbers that you're talking about even being evaluated.
And we also will hope to see what this translates to in terms of overall survival with more time, because PFS alone is limited when we're talking about a campaign over what we hope is going to be several lines of therapy. Let's turn to, if we can, another trial. We have a bunch of ones to introduce, and one we've heard about now for about 6 months is Empower 150. It's been shown in different iterations, and we've seen more mature data over time, including overall survival. Charu, can you outline the trial in terms of its design and what it basically means for us?
Sure. So Empower 150 was one of several trials that was interesting at ASCO this year because of the overall survival results that were presented. Empower 150 randomized metastatic non-squamous lung cancer patients with any PD-L1 expression to receive chemotherapy in combination with immunotherapy using atezolizumab, chemotherapy in combination with antiangiogenesis with bevacizumab, or chemotherapy in combination with both. So in essence, they were comparing quadruplet to 2 triplet arms. And what the authors reported was that the use of quadruplet therapy, namely carboplatin, Taxol, atezolizumab, and bevacizumab, was superior in terms of overall survival when compared to chemotherapy and atezolizumab. So looking at this data, it's interesting to see that that there is an overall survival advantage for a subset of patients. However, what has really come out of this data is the patients that have EGFR mutation as well as ALK translocation.
So in all these other trials we've talked about, the patients with an EGFR mutation or ALK rearrangements have been excluded from these first-line trials because we have a therapy that is generally well tolerated, oral, and has a response rate of 70–80%. And there have been some signals that our immunotherapy agents are not as strong for this group. But these patients were allowed, although they had to have received a prior targeted therapy and progressed on that before going on this chemo-naive, if not first-line trial.
I would say as background, though, that while we have a lot of data that these EGFR and ALK patients don't have quite the same response rate, probably less than half the response rates of patients without these changes, we do have data from other trials, particularly the atezolizumab, showing that response rate is not 0.
Right, no, true.
And I would say that the patients with EGFR mutation and ALK rearrangement formed a small subgroup of this trial out of about
14%, I think.
Yeah, out of 1,200 patients, there were a small subset, and the authors concluded that perhaps this could be a reasonable combination therapy. However, I will say that the survival numbers or the advantage that we are seeing does not really compare to what we can get with targeted therapy with much less side effects and with much better ease of use for the patient and much better quality of life. So while these data are intriguing, I don't think they're practice changing for those two subsets of otherwise well and easy to treat lung cancer patients.
Well, I would say that I think that you can only take them as far as they were tested, which is after initial targeted therapies, and saying that in patients who have received an EGFR inhibitor, ALK inhibitor, or more, and then are progressing and candidates for chemotherapy-based treatment, it could be a good way to integrate immunotherapy into that in a setting where historically we've seen very disappointing results for immunotherapy as monotherapy in the later line setting. Correct?
Yeah, and I think this trial looked at that question of first line chemotherapy and included people who had had TKIs beforehand, and this addresses the question we face in clinic of that patient who got 2 years on osimertinib and then they've progressed. What do we do with that patient? And this trial enrolled that patient, which is not particularly with osimertinib, but with prior TKI. And so I'm glad they enrolled that patient. I'm glad that we have them in this. I have to say I'm not convinced by the data I've seen that this is somehow magically better for that group of patients. It's not clear that this quadruplet is somehow particularly effective for an EGFR mutant patient or for an ALK positive patient. We haven't seen those curves broken out specifically to look at just EGFR mutant patients, and we haven't seen even a table showing the characteristics of these patients. Was there an imbalance in EGFR exon 19 deletions? We don't know.
Much more to learn, and in fact in the New England Journal publication that was really not even covered.
Right.
What is notable, Dr. Sosinski presented a bit on this amidst a lot of other data at ASCO, and it was interesting that the 4-drug combination with bevacizumab was superior to chemo-bev, but chemo with atezolizumab without the bev was not that beneficial. And it raises the question of how much the bev is contributing. It raises the question of whether this might be a specific regimen that is uniquely beneficial for these patients, but still plenty of questions. Another issue was the liver metastases that was called out, and I think a lot of us are suspicious that that is not that specific to this regimen, but it was a highlighted subset.
But to dovetail on your point about regimen choice, if I can talk about something other than immunotherapy for just a moment, I don't like to give frontline patients paclitaxel. If you look at the EGFR and ALK subgroups, this is a population expected to live a lot longer. And so I prefer to avoid the use of a taxane as part of their first-line regimen because I don't want them to live with neuropathy for the rest of their lives. Pemetrexed is a very well-tolerated agent. I think it's become beloved in the thoracic community far in excess of what the toxicity tables represent because of what we're hearing from patients about how they feel. And it may be a little bit mundane, but I'm pretty attached to using a non-taxane frontline regimen for these non-squamous patients, and that's also a limitation for me.
Well, I think that with what is emerging as a range of options of chemo backbones and immunotherapy agents in various combinations, just like we've had various doublet combinations available for decades before this, it is fair to just say these will all work reasonably comparably well. Why you've got to choose one. My view is, at least in the groups that are not EGFR or ALK, you don't get anything from Empower 150 regimen except for hair loss and neuropathy compared to Keynote 189 for essentially a very overlapping population. But let's move on, because we've been talking about the importance of Keynote 189 in the non-squamous population. One of the, I would say, sleeper presentations at ASCO, because it really was, we didn't have the data for it until just before the meeting itself, and so the ASCO program committee couldn't feature it as they otherwise would have, was the trial Keynote 407, which was a randomized phase 3 study of advanced squamous non-small cell lung cancer with any level of PD-L1, randomizing patients to carbo and nab-paclitaxel or standard solvent-based paclitaxel with either placebo or pembrolizumab. So really very similar to the 189 trial, except in a squamous population with a different with a different chemo backbone. And the trial results looked, I would say, every bit as impressive as Keynote 189. Before late May, all we had heard was that there was a response rate difference, which in itself didn't impress me that much, except in the abstract, it was a 23% difference, which is enough to get noticed. But it also had a major, huge difference in progression-free survival and overall survival, both in the broad population and in the all of the different subgroups across the spectrum, from PD-L1 less than 1% to low, and then the highs. And again, leading to the question of, what might you do with various options for the highs, et cetera. But I would say, without any real surprises for toxicity and with very comparable results and benefits for nab-paclitaxel versus paclitaxel, this became a clear, standard, very attractive option for these patients who were not strong candidates for monotherapy with high PD-L1. But there was another squamous trial that I thought would end up being kind of a showdown between two. I would say in the end, not so much. Can you tell us, Greg, about Empower 131?
Right, so this trial was very much the analogous trial, looking at the backbone of carboplatin and a taxane and adding atezolizumab. The trial was somewhat more complicated in design, so 3 arms rather than 2, but it asked the same question. And as you did, I expected to see the same answer, but we didn't see the same answer. The progression-free survival was improved, but on the initial analysis, there was no improvement in overall survival when we look at platinum Abraxane or platinum taxane and atezolizumab. And so, as a consequence, it was a disappointment, even though other years we might have thought this was a practice-changing trial, but in the presence of the pembrolizumab data that said that you could get a better progression-free survival and overall survival, that I think it's hard to say that the atezolizumab trial really guides us.
Right. Again, it's encouraging. There's clearly a pattern here of chemoimmunotherapy is superior, but one of my thoughts in the wake of AACR, where you had the Keynote 189 trial with a survival benefit and then 227 with a PFS but not OS, I thought, you don't bring a knife to a gunfight, you don't bring PFS to an OS fight. And I think that if you have competing options and one delivers a big OS benefit, that's going to get the nod in my mind.
What's really striking from these trials is that these are patients with squamous histology. They're usually older, tougher to treat, they don't have targeted mutations, and yet we're seeing hazard ratios in the 0.6 for the first time. And I think it's a very gratifying time to be a lung cancer doc because of now the power of triplet.
Absolutely. The thought that now, as we're trying to revise NCCN guidelines and up to date and all these other things, to think that we would be arguing over competing positive phase 3 trials is a place where it was really hard to envision us being 10 years ago, when it seemed like you could be O for ASCO in lung cancer. But let's turn to what this actually means in practice. What would you say are the distinguishing features now, Charu, that will lead you to favor one treatment over another, both in the non-squamous and the squamous population?
So I think I would, as before, what hasn't changed is that I still look at histology. I think histology still drives treatment selection. I think getting a sense of what mutation may be driving a particular patient's cancer is still important. But for those patients who don't have any driver mutations, and I think triplet is very relevant, be it any histology now, squamous or non-squamous, we have data to support triplet therapy for both. However, I will say that even though some people may write off PD-L1 now and say, well, the benefit is for all PD-L1 subgroups, why do you even need PD-L1? I will still say that PD-L1 is important because there is that subset of patients with really high PD-L1 expression, above 50%, where if we go back to the 024 data, can we just use pembrolizumab monotherapy and perhaps spare them the nephritis or the neuropathy that may accompany some of the doublet chemotherapy added to the pembrolizumab? And then again, in the same vein, I think for the PD-L1 completely negative, the zeros, I mean, data from TMB as well as CheckMate 227 Are there some patients where we can, spare chemotherapy, perhaps just use IO combination, or, just not give them immunotherapy? So I think we still have questions at both ends of the spectrum, but really, clearly, many more treatment options for our patients now.
My view is that we're increasingly in a world of, for at least the patients without a driver mutation, you're giving pembrolizumab, and the question is it with or without a histology-appropriate doublet? For the high PD-L1 group, I would say the data are very strong with either choice, but in a patient in whom I don't feel an urgent need to give everything up front, and those patients where I would still try to front load, it would be those with very rapidly progressing disease, becoming increasingly symptomatic, losing weight rapidly before you start them, or the ones who have had marked progression between their initial ER CT scan and the PET CT you got to finish staging 3 weeks later. Those are the ones who I'd try to give a combo up front and just give everything you've got, because even with monotherapy, the response rate's 45%, not 90%. But for a lot of the others, if you can spare them the toxicities and the other challenges of chemotherapy for a long period of time, when it may just be along for the ride, I would rather do that and spare the chemo doublet for later. But for the lows and the negatives, most of those, I would be most inclined to give a combination with either the Keynote 189 for the non-squamous and the 407 regimen, one of the taxanes for squames. What are your thoughts here?
I mean, I think I really want to emphasize what Charu just said, that we still need PD-L1 testing for all of our patients. We still need it, and we still need mutation testing. We still need to understand which patients have EGFR mutations. We still need to find those with ALK-positive lung cancer, because the treatment really depends on knowing these things for all of our patients. So I think this is something we can't let our enthusiasm for combination chemotherapy, immunotherapy, regardless of PD-L1 status, while it's a huge accomplishment, we still need to pick our patients. We still need to be good doctors and find the right therapy for the right patient.
Yeah, you make a great point that we wouldn't want to just say, you don't even need to think about it anymore. Give your platinum doublet and immunotherapy, you're never going to be wrong. Yeah, that it still is valuable to distinguish who might be most likely or least likely to benefit. And another thing that was not a featured presentation at ASCO, but is worth thinking about, is the group from UCLA reporting their results in a very small study of giving first-line pembrolizumab to high PD-L1 patients with an EGFR mutation instead of first-line EGFR inhibitor, and showing horrible results, that none of these patients with a proven EGFR mutation responded, and 2 of 10 died in the first 6 months, which is very unusual with this, and really suggesting these are not the same patients, and we shouldn't take shortcuts and not do the testing for these patients who are going to be much better served by doing targeted therapy first. Doesn't mean you would never give immunotherapy, but one of the toxicities was a pneumonitis developing on erlotinib after discontinuing pembro, just highlighting that the sequence may matter. So let's turn to also a big question of, what does TMB mean today? Is this something that you guys are going to be ordering routinely? Should everyone be doing this as part of their initial workup? Jared, what are your thoughts?
So I think we're getting it by default in a portion of our patients already. So there is something of a divide in the non-squamous patients and how molecular testing is being done, with I think academia being wholesale pretty much sold on next generation sequencing with advanced bioinformatics, and a community divide where some are still doing a la carte testing with its advantages of greater speed in some cases and lower cost, but disadvantages of perhaps lower sensitivity for classical changes, and as well certainly less breadth of coverage for rarer changes actionable with off-label drugs and trials. But TMB, if you're getting next-gen with the most common commercial platform used in the US, as well as most academic platforms, you're getting TMB anyway. So for a little over half of our non-small cell, you have that data whether you're ready to use it or not. I think the harder question is, should squamous patients be offered comprehensive molecular testing for the purpose of getting TMB? I think in clinical practice, we've had protocols for years now to get next-gen on these patients, and if I'm going to be honest about it, I can't remember if I've ever been able to action one as a consequence. So that's not really a very satisfying answer. I don't know that this data is good enough right now that I'm enthusiastic about getting next-generation sequencing in my squamous patients purely to get TMB.
Greg, what do you think?
I mean, I think TMB is clearly a biomarker. We've got all sorts of lines of evidence that say it's a good biomarker. But I share your reluctance to say it's a routine today. I think the key thing that I'm waiting for before I tell everybody you got to test every patient beyond those, as you suggest, we already get it on. Once we have an FDA approval that says high TMB patients should get drug X, then I think that's right. I would push to get it done more frequently. We get it right now as part of next generation sequencing. That's the platform that we're going to build off of, and we're just going to expand that when we have an FDA approval in this context. But today we don't have that, and as a consequence, it's hard to say that it's routine.
I would even say that the FDA approval, if or when it comes for this, is not necessarily going to be enough for me to say it's clearly necessary to use or even that valuable to use in clinical practice yet. It's not. These data are very provocative, encouraging, especially the potential for a longer term response, and maybe particularly in the approximately 16% of patients who have low PD-L1 and high TMB, or negative PD-L1 and high TMB. That's a group where I don't think we're hitting it out of the park even with the chemoimmunotherapy. But I would say that the comparisons that are just to doublet chemo just don't apply that much. The standard has changed, and we shouldn't be measuring with that yardstick anymore. We are not talking about overall survival yet. So even if we can, I don't know that it really means we should. I think it wouldn't necessarily be wrong, but I don't know that it would be my leading choice.
I think it matters a lot the direction you ask the question, right? So if you're a practitioner anxious to implement ipi-nivo, maybe you have a super fit, super motivated patient who's clear to you what they care about is some chance at durable control. If you're looking at it from this perspective, then at that point it becomes mandatory to get the biomarker before you do it.
Yeah. Do you?
So I would just add that I will add a little bit of sprinkle of reality here. You know, as
just a sprinkle.
Just a sprinkle. That not all people are actually getting TMB. So at an academic institution like mine, I'm getting next generation sequencing, but I'm actually not getting TMB in real time. And I think that's true for probably half of the community practices out there. So I don't think we're quite ready to say within 2 weeks of seeing a patient, I'm going to be able to get TMB back, and I'm going to be actually using it in real time to make decisions. And I think till the OS data really come out, and like you said, till we have an arm, which is a triplet that's being compared to, you know, a TMB-driven combination arm, I'm not quite sure that we can flatly say we should get TMB in everyone.
Another issue is that the fact that we've circled this point that TMB is a predictor of some value pretty consistently, but not necessarily unique to that regimen. That right. TMB may just be a marker for responsiveness to immunotherapy, whatever way you're delivering it with whatever agent. But one of the issues with monotherapy, pembrolizumab monotherapy, or maybe nivo-ipi is that you still have chemo available. When you give chemoimmuno, we're right now consolidating what has been 2 lines of therapy into one. Right. What are we left with after chemoimmunotherapy, which is going to be the prevailing standard? Is it? I would say it really seems to be docetaxel with or without ramucirumab by default. Any other thoughts on this?
Yeah, you know, I think it was really interesting how we went through a time where every second-line clinical trial was a trial comparing to docetaxel. And then quickly that was supplanted with every second-line trial compared to immunotherapy. But now we're back to docetaxel as the standard of care.
Can't get rid of it.
With or without ramucirumab is the only question that we're asking. And I think that's a question that we can debate for hours at a time. But I think that this docetaxel is probably the new standard in the second line.
Does that factor in for any of your thoughts about, you know, how much does it matter that you've saved chemo if you start with nivo-ipi or pembro?
I think that shouldn't really play into thinking. I think it's a legitimate question, but the implied and therefore preserve your drug doesn't hold. I think we've all accepted over time, and I've heard no major challenges to this, the idea of use your best treatment first, whatever you believe that to be. Because if you don't, you may not get a second chance at coming back.
Well, again, and I think that when you raised that point earlier about that, I think that there's a difference between if it's likely in a negative PD-L1 that chemo is your leading light, they're still going to almost always be fit enough for doing immunotherapy. I'm less confident about saying that about platinum doublet chemotherapy if they decline. So, and I think there may be a real benefit. I agree with you. There's no obvious synergy here, but we have seen some suggestions that there may be a benefit to hitting from two angles and getting two different populations inhibited in first line. Let's turn to another presentation at ASCO that was from your institution by Dr. Arbour and colleagues that looked at retrospective work from Memorial and from Institut Gustave Roussy in France that showed a really consistent theme between the two centers, that in patients who were on daily chronic steroids at a dose of prednisone 10 milligrams or its equivalent had lower response rates, progression-free survival, and overall survival. The question is, first of all, what does this mean, and is this a direct effect of the steroids inhibiting immunotherapy? These were all patients who had received checkpoint inhibitors. So is it the steroids? Are they doing worse because they needed steroids?
Yeah, I mean, I think clearly this is a retrospective effort, and I can highlight the flaws probably as well as anybody. But one of the key flaws is that people who you're giving steroids to are those people with poor performance status, those people with brain metastases. It's a long list of things that are negative prognostic factors. And so you've identified them through giving them steroids. You're taking people with poor prognosis, and we see that they actually do worse. But I think it is a little bit more clear than that, because we did a lot of multivariate work. We normalized for performance status, we normalized for a lot of other things, and it still shows up. And it's important to think this isn't just some sort of funny finding. This is mechanism-based. We know that steroids do affect the efficacy of immunotherapy, and so it makes sense. Mm-hmm. But I think the way I use this data is I'm a big user of steroids. I give steroids to a lot of patients. Yeah. That's right. But so my bar has always been very low, and at a new visit, I would oftentimes hand out the prescription for prednisone. And I've stepped back from that for people who don't have an absolute need. So patients with brain metastases that need steroids, they get steroids. Mm-hmm. But patients who are just kind of a little bit more tired and their appetite's not so good, I hold off on that prednisone prescription now.
I would just point out one thing, is that this data should not be interpreted on how to manage patients when they develop immune-related toxicities. Right. And we should not be shy about giving steroids to somebody who may have colitis or who may have pneumonitis. And I worry that the interpretation of this data may be that steroids with immunotherapy are bad. Well, pre-existing steroids for a patient coming into immunotherapy may portend a poorer response rate. It doesn't say anything about management of toxicities as they appear when a patient is on immunotherapy. So I think there's a very clear distinction, and nobody should take away the point saying you should not be giving steroids to patients on immunotherapy. Nor that this applies to the patient getting pre-medication for a couple of doses before paclitaxel or around pemetrexed, because those trials were very, very positive, and there's no hint that that's really a relevant issue. This is a different situation. One other question that comes up is that we have a significant minority of patients who have autoimmune disorders. I think we would want to make the distinction between somebody who has very significant ulcerative colitis and somebody who has more minor but still arguably relevant autoimmune diseases. Some may or may not require treatment. There was a publication just in the Journal of Clinical Oncology by Leonardi and colleagues that's looking at actually several institutions that suggests that yes, you do see higher rates of, you do see some worsening potentially of the autoimmune disease. You can have side effects, and some will need steroids, maybe a quarter of the patients, but the response rate is still over 20%. Jared, what's your
view about the role of immunotherapies in patients with an autoimmune disorder?
So I think that it depends what the autoimmune contraindication is. For example, a patient with an allograft, the PD-1 pathway is the rejection pathway. You have a near 100% chance of graft rejection if you give that patient a PD-1 or PD-L1 agent, so that's a thou shalt not. But I think this data was practice changing of these patients with autoimmune conditions who got drug. I think it was 23% had an exacerbation of their existing autoimmune condition. It was a higher number than typical. I want to say it was in the 40-ish% range, help me out if you remember the number, that had a new immune-related adverse event, so a little higher than what we otherwise see. But the take-home point to me is that relative to the risk of the lung cancer and the extent to which the PD-1 inhibitor was helping there, including in this population, it was worth it.
Yeah.
And so I think that this provides us some cover and some comfort in treating a broader range of patients based on the rate of exacerbation of the existing autoimmune condition and new events. I think we have to monitor these patients more carefully, be prepared to intervene at a low threshold if they get into trouble, but it opens up the potential for benefit to a broader population.
I'll say one thing that I have to admit is a little bit of a frustration is that this retrospective study had to be done. These drugs have been under study for almost 10 years now. And while I can totally understand exclusion of patients with rheumatologic disorders from the initial phase 1, maybe even the initial phase 2, but to not enroll these patients into trials is really an example of how we too often narrow the inclusion-exclusion criteria of our trials and make it so it doesn't apply to a significant number of our patients.
But it also speaks to the general practice, because if you look at that study, there were only about 50 or 53 patients across several institutions that are being treated. So it is steeped into the clinical practice of automatically you're checking off patients with these diseases getting these drugs.
Let's go back to the group of patients with the driver mutation, EGFR ALK. I think we all agree that nothing we've been talking about suggests that we should not be doing upfront testing. If anything, we're every bit as committed to doing that and doing it up front. What would you say is the importance of Empower 150? Is that the regimen of choice for these people? Are you not convinced that immunotherapy should be integrated with chemotherapy in this setting? So where would you say we are now for these folks?
I think we're very much in need of data. I think that it's nice that Empower 150 included these patients, and certainly I think that takes me a little bit further to feeling that I'm comfortable doing it. It doesn't take me further to believing that there's a clear benefit to giving immunotherapy plus chemotherapy for these patients. I think we need
or that that's the regimen.
Right, or that's a particular regimen. I think we need trials specifically in this patient population. I think we can do trials specifically in this patient population, and I look forward to those results.
It highlights the importance of using anti-angiogenic agents, I think, in patients with EGFR mutation. We've known from different trials that adding bevacizumab in the second-line setting can be associated with an overall survival advantage, and I think it needs to be studied a little bit more, but in no way can we say that this quadruplet is the second-line therapy for these patients.
Let's, before we turn to the questions from our viewers, just briefly touch on post-immunotherapy, and what would you say of the role for continuing treatment beyond progression now with immunotherapy, adding to it, or switching from one to another?
I think it really depends on the kind of response you've gotten in this patient. So if you have a patient who gets no real benefit from that immunotherapy regimen, whether it's single agent or combination, I don't think you should try to nurse that patient along to continue. So if you see signs of progression, they never had a response, and you see new liver metastasis, I would make a change in systemic therapy. By contrast, if you have a patient who had a tremendous response, they're a year and a half in, and one new lung nodule has popped up, I've begun to address those patients like I do my patients with EGFR mutant lung cancer. I treat that oligoprogression.
Right. Okay. And then finally, would you say that there's any meaningful difference among the checkpoint inhibitors in the second line setting at least? I would say the data look remarkably similar, considering that there are some differences that we're seeing in the first line setting. But I'm struck by how amazingly concordant the second line data have been.
I completely agree. These curves, you could put them on top of each other. They're so similar. But we have to admit that the data in the first line look different. And I guess I wonder what it tells us about how we study drugs that these data look so different. Because deep down inside, I think the drugs are the same. I think they have very similar activity, but we do see clear differences in results. Such clear differences that I'm not ready to say one is equal to another, but and I'm going to follow the trials to guide my prescribing. But I wonder what's going on.
There are structural differences between the antibodies we've discussed today, and the very other obvious difference is hitting at the PD-1 side versus the PD-L1 side. I guess the question isn't that important to me.
Right. And I would also say that we've had these agents
as a clinician,
commercially.
I agree with Greg. I'm going to go the way the trials were done, follow the labels.
We've had these agents commercially available for several years, and there are a lot of people, I'm sure, who had progression on nivolumab and then tried another one. If there was meaningful efficacy of switching, we wouldn't be debating this now. We wouldn't still be waiting for the one or two cases to clarify that.
That's really
this
worth
will come down
highlighting.
in the absence of data.
Yeah.
I'll make a statement despite the absence of data. If I have a patient who's progressed on a PD-1 drug, I do not believe that there's enough of a difference between that and other PD-1s or compared to the PD-1s, and you can reverse that equation, that I would consider it a clinically reasonable approach to just switch drug.
And that's, I think, a great point, because people are asking, are these drugs interchangeable? I'm less confident to say that's the case, but at the same time, I'm not inclined to say that there's some major meaningful difference between PD-1 inhibitors and PD-L1 inhibitors based on
That's right. I would
the data.
say, though, that in addition to the approach of oligo treatment, or Jack, I think you put it once this way a few years ago at ASCO in reference to EGFR, putting your finger over the spot on the scan if it's not clinically relevant. I've always liked that way of describing it. All the same, another approach, when I look at the data showing a higher response rate to chemo after immuno, I do not believe, and I reserve the right to be very wrong, but I do not believe that immuno is somehow potentiating chemo. I think you're seeing residual effects still helping people. And so when I think about that, I do think that if you stop immunotherapy because of clinically meaningful progression and you switch to something else, but you have reason to believe that there might be that lingering effect, it's not crazy to come back to that or another drug, whatever you like, at some point.
But we are essentially without data on this.
Absolutely.
So let's turn to some of the questions from the viewers. One is, based on all of the data that have come in, what is your treatment of choice for the patients with 1 to 49% PD-L1?
So I'll give that patient chemotherapy plus immunotherapy. Based on where we are today, I don't think single agent immunotherapy is appropriate for the majority of those patients.
Yeah, I will just highlight that the hazard ratio for that group of 1 to 49% on Keynote 42 was 0.9. So there was really no difference if you gave them chemo versus immunotherapy. And I think we see clear improvement in survival with Keynote 189 and with 407. So I think it would be a chemo triplet combination for me as well.
So again, just like, as I said, the comparator today in real world terms is not chemo alone. It's now chemo-immuno, and you do have a choice of a few different positive trial results, and I agree that histology-appropriate chemo-immunotherapy with pembrolizumab bubbles up at the top right now.
I would say, though, that I don't feel a total compulsion in the 0 to 49% group. I think it's still legitimate to do clinical trials guaranteeing exposure to these agents in a consolidation or maintenance strategy. I think that's actually consistent with the principles gleaned from this data. And for the patient with a relative but not absolute contraindication to the immunotherapy drugs, that patient where we may have a little bit more fear, but it's not going to totally stop us, I think it's legitimate to reserve the immunotherapy for second line.
Okay. Now, somebody asked also, does the actual agent matter? And my view is, we've talked about how they're more similar than different, but I would certainly be inclined to use the agent where the trial employed, do what the data show you, rather than just cavalierly presume they will be exactly the same You agree then?
Yeah, I mean, I think the differences that we've seen between these agents reflect more the populations accrued and the way the trials were designed than structural differences between the antibodies. The classic example might be the Nivo-Pembro combination, where in lung, you could look at this data and argue that perhaps Pembro looks better, but in contrast, similar experiments in head and neck, you'd be arguing that Nivo looks better. I don't think there's a disease by drug interaction. I think you just have different patients, different comparators, different trial designs.
Somebody had we have a provocative question. We have data for squam and non-squam, but what about a patient with large cell neuroendocrine carcinoma? Would you use the 189 approach, or would you be inclined to use Pembro monotherapy? Would you be inclined to do a platinum and etoposide with Pembro, which I think would be my preference.
Yeah, I think this is faith-based medicine. We have very little data to guide us here, and I've always fallen, my religion for large cell neuroendocrine is that it's a non-squamous entity,
okay.
And so I give pemetrexed platinum, and now in this day and age I'll add pembrolizumab to it as well.
I feel the same way, especially if they're TTF1 positive. Then
okay.
I'm even more comfortable with the use of pemetrexed.
I would favor an etoposide-containing regimen for neuroendocrine histology still. I think there's no right or wrong answer here, but that would still be my preference.
Yeah, this is one religious argument where I wouldn't fight to the death over this. But, and then the question of what about a patient who progresses really rapidly within the first 4 months or so after chemoimmunotherapy. And that, are we really left with chemo, or are we left with docetaxel with or without ramucirumab? And there are some data from the REVEL trial that suggests that the patients with rapidly progressing disease may get a real benefit from ramucirumab. What would your approach to this kind of situation, which is not going to be rare? But
this is the patient who should go on a clinical trial. If you have rapid progression after a use of our most active agent, going back to the well and repeating cytotoxics, and thinking that you're going to have a high probability of response stands in contrast to the data that we already have. Ideally, that trial should be at UNC.
Yeah, right. I mean, that's the problem is, trials are always the right answer, but they aren't universally available.
And I will say that rapidly progressing patients are seldom good clinical trial candidates. I mean, those are the ones that are, in pain, their performance status is poor, or their labs are tanking. So I would say that our general gestalt for these patients at this day and age, at this time, would be docetaxel and ramucirumab if they're able to receive it.
Your thoughts?
I would use docetaxel, mostly just docetaxel.
Okay.
The only other thing I would add is that given the lower probability of cytotoxic response at this point, if you don't have a trial, you need to also be at least talking to the patient about hospice and making sure that further treatment with lower probability of response is consistent with their values.
So clinical trial or hospice, nothing in between.
Well, this is also...
Well, if they're not a good candidate, I'll send them to Penn.
We would also love to know whether it is true that patients may do better with chemo, even garden variety chemo after immunotherapy. That we need to get some actual data on, at least prospective data. So we could go on forever. This has been a great discussion, and there's going to be so much more to talk about in coming months. We'll have to do this again. So this has been a great discussion, and I hope you found the information valuable to you in clinical practice. Thank you for watching OncLive News Network.